Okay, so we're gonna let folks trickle in and we are live. Give it about 10 seconds for folks to join us today. So hi everyone, Liat here from Hyro, and I'm thrilled to be your session host for today. Thanks for joining. If you have any questions or comments, feel free to use the chat on your screen, which I'll be moderating at all times. And our speakers and close friends today are Patrick McGill, Chief Transformation Officer at Community Health Network, Gardner, CEO of Kyruus, a Hyro partner, and Dr. Rupol Gupta, Clinical Services Director at Kyruus. So they're going to share their expertise on why data is the key to your digital front door. Graham, take it away.
Great. Well, thank you, Liat, and good morning or good afternoon to everybody. I understand it's already been a great day talking about the possibilities of the digital front door, next generation AI. So what we wanted to do here for the next 30 minutes was to unpack that a little bit and talk about some of the building blocks, and specifically some of the data that goes into ensuring that that digital front door and that patient experience is a good one. For those of you who have not had the pleasure to meet yet, I'm Graham Gardner. I serve as the founder and CEO of Kyruus. Kyruus, as many of you know, is an enterprise provider data management and scheduling platform that helps organizations ensure patients are getting routed to the right in-network provider. We have the good fortune of working with many of you, about 900 hospitals, 500 independent medical groups, and about 70 health plans around the country. In addition to dozens of different digital health companies and helping to ensure that the data we're collecting and managing on behalf of our clients also populates those applications and the experiences that are being built on that. So today I'm very fortunate to be joined by two fellow physicians to help lead this conversation. Dr. Patrick McGill is the Chief Transformation Officer at Community Health Systems, and my colleague, Dr. Rupol Gupta, leads our clinical services here at Kyruus. So why don't I take a moment, Patrick and Rupol, just to give you a minute to introduce a little about your backgrounds and your roles at the organizations. Patrick, if you want to start us off.
Absolutely, Graham. Thanks for having us. So, like you said, I serve as the Chief Transformation Officer at Community Health Network. We're based in Indianapolis, Indiana, a mid-sized health system. As the CTO, I have a broad range of responsibilities, overseeing everything digital, IT, analytics, pop health, value-based care, and then I have some operational responsibilities as well. And I'm a still practicing family physician 1 day a week.
Terrific. Great. Thank you. And Rupol.
Hi, my name's Rupol Gupta. I'm a general pediatrician based in Leawood, Kansas now. My background is really working with underserved communities, particularly in urban Philadelphia and urban Kansas City. I've also had some background in medical communications and then clinical and operational leadership, which is really what led me to Kyruus. Here at Kyruus, as part of the clinical team, we help with implementations and specifically configuring providers and making sure that the clinical voice is heard as part of access initiatives that health systems have. And we extend that expertise to health plans as well as the medical groups that we work with. And we help inform how we're doing the job that we're doing as a health IT company and making sure that we're meeting the needs that frontline healthcare workers are facing.
Great. Well, thank you both for joining us. Patrick, maybe I'll start with you. You've been at CHS for a long time, and I wonder how over the last decade you and the organization have thought about that transformation around patient engagement and the digital front door.
Well, certainly a lot has changed over the last few years. Last 10 years or so. If you think about 10 to 15 years ago, really a lot of organizations were implementing their EMR. We're an Epic shop, so we've been on Epic since 2012. As we went live with Epic, we thought that was our front door. And then as we continued to mature, you start to think about other options, online scheduling, direct scheduling, some of those aspects that people want, the consumerism. Think about the last 5 years, even before COVID, it was really kind of you started to see the rise of consumerism and these ideas on segmentation. Certainly COVID. You saw the launch of digital telemedicine, telehealth really took off. And so now after we're coming out of the pandemic and things are somewhat coming back to normal, what does that look like around engagement? How do we engage with people? How do we keep them engaged along that journey? Oftentimes we talk a lot about kind of the horizontal journey that patients and how they experience our health systems. Oftentimes health systems are organized vertically. So we think about a service line or a hospital or a clinic. but that's not how patients experience us. So we've really tried to gauge that engagement and also measure the engagement, which we can talk about a little bit later. Measure that engagement along their horizontal journey. And I think that's oftentimes it's digitally enabled. It's how do you get people connected at the right time, the right service, the right provider, to really meet their needs.
That's great. And Patrick, I know as we work with a lot of organizations, a lot of them begin to realize that the information, the different pieces of content that they need to publish, for and expose to patients, sits in dozens of different silos across the organization. So I wonder, when in that journey did you begin to really think about the underlying data, and how did you go about, pulling that together and thinking about the governance of that?
Yeah, really, it was many years, kind of early. It was probably 7 or 8 years ago, I think, when we started having this conversation. And to your point, there's a lot of data that sits in different systems, but it's different systems for different purposes. Mm-hmm. So if you think about physician specialty, and then take that to the next level of physician practice preference. So I'm a family physician, but I don't treat kids. I don't see kids very often. I have more of a geriatric practice than I have a younger practice. I don't do sports medicine. I don't do OB. I don't do a lot of procedures. So if you just went off of my family medicine specialty, you would think that I did everything. And when patients came in to see me, they would be disappointed to know that I don't do a lot of things. However, there are things that I do very well and, things that I specialize in. So how do you get people connected? And that's really where we started many years ago. And this is in primary care, and Dr. Gupta is a pediatrician. So it's a similar concept. It gets exponentially more difficult when you start to think about specialty care. And so, really, how do you start to, when you want to build those connections, you got to have the data that you need. And oftentimes what we found is that credentialing systems, other systems were based or built on that specific information. You need to know that I was board certified in family medicine or board certified in pediatrics. But beyond that, it's not going to tell you anything about my practice. Whether I practice with APPs or whether I practice with other providers. So I think and it started 7 or 8 years ago when we started down this journey. We knew we needed the information, the data, to your point, to really start to build those connections.
That's great. A nice lead in, Rupol, for you. I mean, I think what we have found is that clinician engagement is critical to buy-in, for these kind of transformational changes. And so often their clinical practice is a very personal thing for them. To Patrick's point around wanting to ensure that the right folks are coming in to see them. Do you mind just kind of walking through your experience in engaging with clinicians and just how you approach collecting and managing that data?
Yeah, absolutely. I think you can see from Dr. McGill that he already stole the thunder, knowing that it's really the data that you build that foundation on. And so what we do as a clinical team is focus on listening intently to those provider leaders, as well as the frontline providers who get engaged for these access projects. And there's several reasons why that's important. One, it helps that differentiation, right? Dr. McGill has already alluded to the real nuances in his practice that patients need to know about. There's also noise there, right? And so what we help to do is differentiate between what's important and what's noise in the types of configuration that we work with our providers. So that might mean at a division level, defining what's standard for that organization to be able to offer in family medicine. What are 80% of people doing? And then what are 20% of people doing? And how do we make sure that we're able to get at those specifics for that smaller group, but also help define standards across the larger group? So what we've really found is that involving clinicians in that conversation and really making sure that they're active participants, it builds their trust, it builds the accuracy of information that patients are going to see. And it really helps make sure that that data can be valuable in the different purposes that it's going to be used. So it ends up being that these projects end up having larger organizational impact.
Yeah, Rupol, as you know, I tell a very personal story, Dr. McGill, to members of our team. When I was practicing as an internal medicine, you'll remember we're working too many hours. I practiced before the 80-hour work week came in, and when a very complicated patient, potentially someone without housing, would come into you with just a myriad of things going on. Your pager was going off and trying to get back to the ICU and things like that. It was a very overwhelming and frustrating experience. Years later, when we were working with your organization and others, building out what has now become a 30,000 term library of every symptom and procedure, condition that we can map to clinicians. I remember going through some of the templates for family medicine and seeing homeless medicine there, and just having this profound experience, knowing that someone was going to sign up and say, I'm the right provider for that. I sign up. I want to see that person. I'm equipped to deal with someone with those kind of needs, and just knowing that we're providing an opportunity for everyone to be who they were and engage with patients and serve them as well as possible. So with that, Patrick, I'll maybe come back to you and ask you to maybe go a little bit deeper in terms of the clinical experience at Community Health. Did you bring physicians on that journey with you, and how critical was it to ensure that clinicians felt like they were best represented in their digital self as you began to populate other digital front door applications?
Yeah, that's a great question. So I think, as Dr. Gupta said, you have to bring the physicians along, right? There's a lot of things that have been taken out of physicians' control, but the schedule and the types of people that they see are the two things that they're going to hold on to until the end. And so really you have to come at it with the approach that, look, we're not here to take away control from you. We're actually here to enable more control for you to be able to do the things that you want to do, treat the conditions you want to treat. This is about connections, and this is about, again, there's a lot of things in medicine today that reduce job satisfaction or contribute to burnout. This is one of the things that we're trying to do to improve that, to make the right connections for patients, to get the right people into your practice. And I think, physicians, once you start talking about specific conditions or specific subspecialization or specific patient populations, they get really engaged because of the story like you just told, or because of other conditions, other treatments that they enjoy doing. And so oftentimes what might seem like a difficult conversation becomes an easy conversation. Now, the difficulty is getting them to actually sit down and think about all the things, to your point, the 30,000 terms and mapping. That's the difficult part, getting them to stop for 5 minutes to sit down and think, okay, this is what really applies to me and what doesn't. That's the difficult part. But conceptually, I think bringing them in early, because the first fear that they're going to have is, you're just trying to take away control of my schedule. Yep. And that's not it at all. You're trying to tell me what patients I need to see. That's not it at all. We want to engage the clinicians and physicians and APPs in this conversation.
No, that's right. And I think, the other benefit we've seen in engaging, at the individual physician level is it allows them to also contour their practice early on. So what, we had thought we might take a claims data driven approach to mapping providers, but that often only reflects a practice years into someone's experience set, and even then may not reflect actually what they want to see. And so the ability to say, hey, look, I'd like to not only be a sports medicine, but really just specialize in shoulder, and so please prioritize me for these kind of things, really, again, allows them to express and engage with the right member populations. Rupol, I'll come to you, because I think one of the reasons we're so excited about the partnership with Hyro is that it begins to move matching to a completely different order, right? Today, if we type in AFib or AF, we can map that to an electrophysiologist, but conversational AI opens up this idea of beginning to have a conversation with the patient around that fluttering in their chest, right? And what might that mean, and helping to triage that. So I wonder if you could, talk a little bit about, how you're beginning to think about conversational AI, and again, that clinical routing as a backbone of that.
Yeah, absolutely. I think, again, it's really grounding ourselves in knowing that having good data is going to be the make or break of whether conversational AI works well. Just thinking about that, right? If you are focusing on the claims data rather than what a provider really considers themselves very good at seeing, then you could completely be missing the point. And so what you really need to do is to be able to get that appropriate specific matching. And so, ultimately, right, the quality of the answers that we generate is really going to be dependent on that. And here you're kind of taking, you're using conversational AI, which is involving the patient and their questions and what they share. But then you're having technology help make that decision partially on behalf of the patient, right? Maybe you're serving up options. Maybe you're recommending one option. And so if the foundational data is bad, it doesn't matter what you do, you're going to make things more problematic for the patient. And so, how will this go right? This will really go right if we make sure that we are taking the time to get that appropriate mapping correct. The way that it'll go wrong and the way that you're going to lose trust immediately with physicians is if you don't pay attention to getting this right. If a clinician goes, the first thing the clinician is going to do is go into the tech and try it out themselves. And they are going to figure out how to break it, and if they if they perceive that it's not working well, they're gonna be the ones to pump the brakes and say it's not ready for prime time. And so, in contrast, let's say we surface availability that has parity between what's available on the patient portal and what call centers are working. You're really going to have much better results and much better engagement by patients and trust in that tool if you have that parity. But if you offer a different experience, you either will have patients going one place and the other place, or you'll have patients seeking care elsewhere because they can't get consistency.
Yeah, no, it's I think one of our principles at Kyruus from very early on was this idea of providing consistent data across all the different channels through which someone might be looking. So whether that was, getting the name from a referring provider, going online to do research and then calling into the call center, that had to all be the same. Graham Gardner had to be the same doctor across those, not internal medicine here, cardiology there, interventional cardiology, somewhere different. But I think the number of channels through which patients are accessing is getting even broader, right? So Kyruus, one of the reasons we began to extend into the health plans was that a third of patients were actually starting their search for providers on the health plan website. A third of them start somewhere else, whether that's an online search or a digital care app or a care navigation company. And so, Patrick, as you're thinking about how patients are engaging with the system, maybe you can tell us some of the exciting applications and places you're thinking about this data going to ensure you're there to capture and bring them into the organization.
Well, I think you highlighted one is that patient facing, that patient search. I mean, that's really the bread and butter. That's where a lot of these things start. But I think organizationally, as operational efficiency and access and everything becomes so critical to success of many health systems with the environment that we're in today, how do you enable staff members to also navigate? I think also oftentimes we think about this as a patient-facing tool, but to your point, it could be an internally facing tool.
Yep.
We're a big system, right? We have 1,500 providers that we employ. We have another 1,500 that are not employed that work in our system that are aligned. We're across half of the state, and we're mid-sized, right? I can't imagine doing this in a larger system. I don't know who does what in the system. We kind of lost the doctor's lounge. We laugh about that, but how do you understand who does what and what their specialty is? And so when I'm navigating a patient that I'm seeing navigate, or my staff is navigating them to the specialist, where can you go for that trusted source of truth to really get the patient to the right specialty? I'll tell you this, we had an experience a couple months ago, or actually probably about a year ago, where, and this goes back to all the things we've been talking about, quality data, specificity on specialty. And so when you search online for a general surgeon, the bariatric surgeons actually popped to the top. And the reason is they offered online scheduling, whereas some of our general surgeons didn't.
Mm-hmm.
Well, what that did is when they were, created that competitive nature of physicians, the general surgeons very quickly said, fine, open my schedule up. We'll have online scheduling as well, because we want the referrals and being driven to our practice. So to Dr. Gupta's point about physicians getting in there trying to break the tool, I think it's also engaging them to say, this is how you're going to appear in the tool. And when people are searching for you, is that what you want? And again, to your point, it goes across all the channels, whether it's externally facing, internally facing, web, mobile, phone, whatever it is, you've got to have consistency and provide the data.
Yeah. Yeah, we just released some data recently that shows about 80% of people want to actually schedule online. And I think as providers begin to realize that, we often see a journey that organizations go through where sometimes the generalists are the bravest, right? They're trained to block and tackle everything. So, folks will go online with primary care schedule. And once the world doesn't end, the cardiologist will sign up, and then GI, and eventually everybody feels comfortable, again, because the routing is in place, that you're going to get the right kind of patient referred into you. Well, we'll open this up here in a moment to the audience. I see a couple things already beginning to emerge on the chat, but maybe as a question here before we get started and everybody thinks of what they'd like to ask, any advice for organizations thinking about, beginning to really expand their digital front door in and around data? Any kind of lessons learned, mistakes perhaps that you've made along the way that you'd share with other organizations? Dr. McGill, I'll start with you again.
I think the first thing I would encourage people is what we talked about earlier. You've got to engage clinicians. You've got to spend the time. Data governance, data quality, those things are not sexy, but they will make or break you. And so you've got to understand where your data is, where it's coming from, the quality of the data. You can't just make assumptions when you're doing this work. I think that's the first thing. The second thing, we talked about it, engage not only your physicians, but all your clinicians and office managers, other people who are referral specialists, other people that are involved in that scheduling process. It's not just about the physicians, it's about that whole continuum. And then I think the third thing is, it goes back to the data. It's really understanding, here's what data you have, here's what data you need, and how are you going to cross that chasm to really go to the next level. And I think that's, we preach this, right? You've got to start with your processes, then understand what data you have and need, then go forward. Oftentimes people just dive in. They want to go really fast because it's urgent. But you've got, it's that old adage, you got to go slow to go fast.
Yeah. Thank you. Rupol, anything to add to that?
Yeah, I think that the biggest troubles I can see with access projects not going well as they could, right, is if people aren't talking to each other. And so I see a question in the chat from Pam Landis just around, providers maybe wanting to put the brakes on projects, right? And so how do you make sure that you provide that context and allow that time for the change management to settle in, and then to let people really recognize that this is meant to help the patients get to care, right? You're not just thinking about whether you're having a bad day based on what patients you see, but did the patients who needed to see you get to the right person and be able to see you in a timely manner? And ultimately, did they get better, right? So there's a much higher goal that we have in this really nuts and bolts work that we're doing. And so communicating and making sure that we're really taking into account each other's perspective, while also recognizing that we have to push the project through, so you can't just be a blocker from, there's a lovely book by a one-page story from Dr. Seuss about the Zacks, I think, and they stop everything in the middle of traffic, and everything gets built around them, right? So you have to be a stakeholder and be active, and don't let technology take control of you. And think about the bigger goals.
Spoken like a true pediatrician to bring Dr. Seuss into the conversation. That's great. I want to pick up on, I think, what may be another aspect of Pam Landis's question, which is thinking about the patient here and what the patient is looking for. And I'm curious, Dr. McGill, did you do specific surveys with patients as you thought about the digital front door in terms of what they were looking for, how they engage with content and the system?
In the very beginning, we didn't, because it was pretty obvious, right? We needed to offer up online schedule. We needed to do provider matching. I mean, those types of bread and butter basic things, we didn't. Now, what do we do now? Let's fast forward till today. We do a couple things where we measure. We don't measure access from third next available or what's the lead time to get an appointment. We actually ask people in a survey, did the appointment you received meet the needs that you had, meet your needs? Mm-hmm. Yes or no. If they answer no, then they give us the reasons. And we use that qualitative feedback to be able to go back and drive improvements in the process. So, I think we try to go to the next level to really understand access from the patient experience lens. And it's more than just a number like a third next available or whatnot. I think when now we have a very robust patient family advisory council where we will, ask questions on how do you want to schedule, how do you want to engage, some basic things, and then we'll do some testing around a mobile app or other things like that. But really what we're trying to do is understand real time, in the moment feedback on what's going well so that we can then continue to design and redesign our processes.
Yeah, I think one of the principles that's always driven us is this idea of not finding the best provider, but finding the right provider, and acknowledging that changes all the time. If you're looking for a flu shot, right, might be defined by it's down the street today for $10. It might even be a doctor, right? Whereas if I'm looking to establish primary care, I'm looking for, potentially a 30, 40-year relationship with someone, and what are the things that matter to that? And so, to date, I think we've seen it as our role at Kyruus to collect the data and have it all be available. So there's 100 different facets you can sort through to figure out what's right for you in that moment. One of the things we're thinking about going next is how do we begin to actually coach people through that journey as well. I think one of the roles that we all played in practice, not paternalistically, but was to be a source of information and guidance to folks, and to say, hey, look, you need your parathyroid taken out. You're going to see that person one time in your life, probably under anesthesia. These things might not matter, right? What really matters is whether their hand shakes. Whereas if it is a primary care relationship, do you want to see another runner, right? Who's not just going to say, stop running if you've got leg pain. How do you begin to think about access, availability, those kind of things? And, I think as we think about digital health, it's not enough just to push all the information there. How do we think about true navigation, right? And ensuring people have, the context also for the right information to get in. So, well, good. I don't see any other questions in the chat. Are there any other thoughts on folks' mind?
Well, I think just another quick thing from my perspective is just making sure that inclusiveness is there, and that as you're surfacing provider data and offering that transparency, you're thinking about what that context must be for the patient from wherever they're coming, thinking about their background, their language, all of those different facets that they might not want to have to experience over the phone, right? But they're experiencing it online and trying to get care, but making sure that you're building your access toward making care accessible for everyone.
Now, Rupol, I think that's a very important point. Let's expand on it a little bit. I think one of the things we noticed very early on at Kyruus was different search logs when people were searching online versus calling into a call center, right? Gender affirming surgery. People are more comfortable asking into a computer, and we think one of the values we're providing with videos on philosophy of care, or even just pictures, is allowing people to look for shared identity and philosophies of care. And I think it's a critically important point, Rupol, that if we're going to serve everyone, we need to think about all the kinds of information and the language levels, even of the information, so that everybody can feel like they can be appropriate and come in. So
yeah, I think that's a great point. I would echo what Dr. Gupta said. I mean, I think that's so important for inclusiveness and allowing people to comment in the chat about it goes both ways between the right provider and the right patient. Totally agree with that. Absolutely agree with that. And I think as we continue to evolve and improve, improving that matching on all attributes, I think is very important.
What a wonderful place to leave it. So thank you both for the time today. Really appreciate it. And Liat, I will turn it over to you and wish you the best of luck with the rest of the conference.
Thank you guys so much. And of course, for those who couldn't make it, this will be recorded and provided post-event. Thank you to you three amazing people. Right after this, we have a 5-minute break, and then we've got my favorite part of the day, which is the fireside chats. Join either your IT and digital leader fireside chat, patient access and engagement fireside, or contact center operations fireside. And you guys are welcome to join too, but I'm sure you're all busy and going about your day. So thanks again, and we'll see you guys soon.
Take care. Bye-bye.